is their second part of the guideline, which is the chronic primary pain. Now that is something that is very different, and the questions that might be going through your mind and should go through your mind is, if there is a chronic primary pain, then is there a chronic secondary pain or a tertiary pain? How is this all different from chronic pain that we've all been seeing guidelines and we all have been dealing with for the last 15, 20 years in terms of support and managing such patients? And the important point to understand is, are these two separate entities, or can there be an overlap? Can people have both going on? So to take the first things there, next slide, is the aspect of chronic secondary pain. Now, all of this stems from the fact that in 2019, the WHO International Classification of Diseases, which used to be like from 1 to 10, they are now going to come out with a ICD-11, which is going to come into force from January 2022. And along with the International Association for Study of Pain, the WHO has ensured that in the brand new ICD-11, for the first time ever, chronic pain is going to be considered as a separate entity and a disease in its own right. This is massively important. This is worldwide, globally, very, very relevant, because up till now, trying to get policy and funding decisions for chronic pain at a country, at a global level, has been very difficult. One of the big reasons why it still is not being shouted out from the rooftops that there are more chronic pain sufferers than all of cardiac disease and stroke and every other long-term condition put together is because sometimes you do not have a classification that allows this to come out. So ICD-11 has finally allowed that diagnostic coding, that classification to happen, to treat this and to get appropriate funding and policy implications in place. So that's the background to why the ISP has brought this. And in their wisdom, what they brought out was this concept that we all understand chronic pain is more than 3 months, but let's talk about chronic primary pain and secondary pain. And by chronic secondary pain, they said anything that's related to cancer, that's related to post-surgery, or has got secondary MSK. So for example, like hip and knee replacements that have been done, arthritis-related pain from a variety of joints, secondary visceral pain, or even neuropathic pain, or headache and orofacial pain is secondary pain, you know, consequent to some intervention or known structural problem. Next slide. But then they brought about this concept of chronic primary pain, everything that didn't necessarily fall into that essential boxes of chronic secondary kind of pain. They said that conditions like fibromyalgia or irritable bowel syndrome or low back pain, which is non-specific, or even some forms of migraine, wherein you do not have a clear understanding of the condition as yet, and we do not as yet have a clear way of delineating it, and the pathophysiology is unclear, that is what we should call as chronic primary pain. And what it does is it moves away from calling things as psychologizing or somatic symptom disorder. So that was ISP's intention of creating this new entity called chronic primary pain. There are other ways of looking at it as nociplastic, or there are other terms that have been used for it in the past, are still being used in literature, but this was introduced by ISP in 2019. However, they make sure to say that primary and secondary pain can coexist, and that's what the NICE guideline also brings in. Next slide. And what they then say, the second part of this guideline, once they've defined what chronic primary pain is. So you can see that they are assessing all of chronic pain, but the chronic primary pain, they talk about how to manage it. And the guideline goes into great detail about the non-pharmacological and the pharmacological management aspects. What's come out in the popular media in the last week, unfortunately, is the big picture on the non-pharmacological. But the evidence and the way NICE looks at it is that exercise programs, a brief course of acupuncture, psychological therapies like CBT and ACT have been the ones that seem to have a better quality of evidence and if clinical and cost effectiveness to offer. They'd say that we shouldn't offer any TENS or ultrasound, and the pharmacological management is going to be going along purely antidepressants, mostly because of evidence base, but not to give anything else. And they do have a plan on how to help patients change or move in case they need to change from one drug to another drug. Next slide.
So I think as Deepak has covered some of this already, but certainly when the draft guideline was first put out for consultation, there was an awful lot of controversy around the content of the guideline, particularly around the seeming absence of medicines recommendations that were there at the time and which have continued into the final draft, into the final guideline itself. Some of the concern was that a real lack of medicines being recommended as part of the management for chronic primary pain, which, as Deepak has explained, being a new diagnostic criteria has led to a bit of confusion, and obviously has some implications in terms of evidence base. If you've got a new diagnosis, then the evidence base may well be limited. Of more concern to me as a practitioner, and I think to many people living with pain, was the apparent implication, or at least that's how it was being spoken about, that people currently being prescribed medicines as part of their management for their pain condition would have them withdrawn or stopped. And that's probably the bit I want to focus on for the rest of my slides. Next slide, please. So I think it's important to look at what the guidelines actually say, because that can sometimes get missed in the heat of debate. So what the guidelines have said is that for chronic primary pain, so this new diagnosis, a range of diagnoses as Deepak has explained, the evidence base, such as it is from the NICE perspective, would suggest that some antidepressants may be useful, particularly in improving quality of life, sleep, and psychological distress. Then there is also some evidence that has come from those reviews undertaken by NICE that some of these antidepressants actually do have an impact on pain intensity as well. So may well be of benefit for some people. I think it's important, as it always is when we're using medicines off license or for indications that people are less familiar with, to explain that that doesn't necessarily mean that everybody with chronic primary pain has depression, and that's certainly not what the evidence suggests, but simply that the mechanism that these medicines work by seems to have some impact in some of these primary pain conditions. I think where some of the controversy has arisen is in what seems to be a long list of things that NICE have suggested shouldn't be initiated. And certainly I would say from a pragmatic perspective, the idea being that these medicines are less likely to be of benefit, but there was significant evidence of harm being caused by some of these medicines. I think when you look at that list, what probably strikes all of us working out in practice already is that some of those medicines, such as antipsychotics, we would probably not want to be initiating in most people under any circumstances. Others of those medicines, we already know there is a really good evidence base of limited benefit, but significant evidence of harm, particularly in long-term use in other pain conditions. So some of those medicines that are on that list are probably not a huge surprise to those of us prescribing in pain already. I think the difficulty here is, as Deepak has already explained, is the crossover between chronic primary pain and chronic secondary pain. And so where patients present with elements of both conditions, or certainly more than one condition, and I would say it's pretty uncommon to see somebody with only one pain issue that they're trying to manage. And I think what NICE has tried to improve in this final guideline is the explanation that they understand that those conditions can coexist, and that they advise practitioners to review guidelines appropriate to the other conditions that people are presenting with. And so it does leave the options open to use medicines where appropriate and where people may have crossover between conditions. Next slide, please. As I said, I think one of the main concerns, certainly for people living with pain at the moment and who may be receiving some of these medicines on prescription is the worry that as a result of this guideline, those medicines will be withdrawn. What I would say is the guideline does make it pretty clear that where people are benefiting from using these medicines, they should not be withdrawn, but certainly that a conversation should be had to explain the lack of evidence to support using medicines in certain conditions and where that is appropriate for the individual patient. What I would say as a pharmacist is this is just should be normal practice. So regular medicines review to make sure that medicines remain effective, are not causing adverse effects which are interfering with a person's ability to live with their condition, to manage their condition, to function on a day-to-day basis. That should all be part of standard practice. Unfortunately, it isn't always, but certainly perhaps we can use this new guideline to promote the need for regular reviews of medicines to ensure that they're remaining effective and are not causing adverse harm to patients taking them. But I would like to stress that where medicines are benefiting the person and where they are not demonstrating harm, NICE have not suggested that those medicines are withdrawn. Next slide, please. So what are the implications in practice? I think the first really important one is that what this guideline does promote is the need for holistic management and for that management to start from the very first appointment. So at the moment, pain management services often remain an end-of-the-line option for people rather than something that is offered right from the start. And it would be nice to think that we can use this guideline to promote the need for better, more supportive services out in primary care so that people can access a rounded level of support right from the start. And that might enable us to move away from the reliance on medicines that we currently have. Although medicines may be of limited benefit for the majority of people based on the evidence that we have, there is still a need to use medicines. So what we need to make sure is that where they are going to be used, that they are offered as a trial and that only medicines that are shown to be beneficial are continued so that we can limit any harm to patients. Last slide. So from my perspective, what I've been discussing with my management is firstly, obviously, the need to reassure people, particularly around this idea that medicines will be withdrawn without conversation benefit. For the majority of people, based on the evidence that we have, there is still a need to use medicines. So what we need to make sure is that where they are going to be used, that they are offered as a trial and that only medicines that are shown to be beneficial are continued so that we can limit any harm to patients. Last slide. So from my perspective, what I've been discussing with my management is firstly, obviously, the need to reassure people, particularly around this idea that medicines will be withdrawn without conversation. I think it's important to remind us all that NICE is one source of guidance, but it isn't the only source of guidance, and there are other guidelines that can also be used to support people living with other conditions such as complex regional pain syndrome, fibromyalgia, and so on. And as practitioners, we need to take all of those guidelines into account when making decisions about treatment. And then we need to make sure that these guidelines are taken into account locally for local guidelines, but that they're not taken into account in isolation to everything else. So the need to continue to develop holistic pain services and sources of support for people living with pain. Thank you.